Now let's study esophagitis and related disorders. First topic is lacerations. Now let's discuss severe type of laceration called Borhave syndrome. What happened to this patient? Shift her to OT.
She had severe chest pain and shortness of breath, then she went into shock.
Okay, he may be having MI, but further investigations should be conducted to find out the cause. When we investigated previous patient, we found out he had Borhave syndrome. In Borhave syndrome, transmural tearing, which means tearing all layers, as well as distal esophageal rupture also occurs, which will lead to mediastinitis. Now let's discuss another type of lacerations called Mallory-Weiss tears. Normally before a wave of antiperistalsis, reflex relaxation of gastroesophageal musculature occurs, but in case of prolonged vomiting, which can be due to alcohol intake, reflex relaxation does not occur, as a result of which refluxing gastric contents overwhelm gastric inlet and esophageal wall, gets longitudinal tears near gastroesophageal junction. These tears are called Mallory-Weiss tears. There is no treatment required for Mallory-Weiss tears, but surgical intervention is required for Borhave syndrome.
Now let's study esophagitis. First type of esophagitis we study is chemical and infectious esophagitis. Symptoms may range from pain on eating called odynophagia to hemorrhage, stricture or perforation in severe cases. First reason of chemical esophagitis is accidental ingestion of household cleaning products by children. Pill-induced esophagitis: when a pill gets lodged and dissolves in esophagus, it causes harm to esophagus. Iatrogenic esophagitis, which can be due to chemotherapy or host versus graft disease. Fourth is due to desquamative diseases like epidermolysis bullosa, etc. Let's study infectious esophagitis. It can be due to number 1 herpes infection, number 2 cytomegalovirus infection, number 3 fungal infection, mostly candidiasis. These infections occur mostly in immunocompromised persons, but herpes infection can also occur in immunocompetent persons. Morphology. Morphology varies with etiology. When there is injury by chemicals, we can see neutrophilic infiltrates, which are usually present or absent in this case. In pill-induced esophagitis, we can see that it usually occurs at site of already present stricture, and it can impede passage of luminal contents. In iatrogenic esophagitis, intimal proliferation and narrowing of blood vessels is seen. Due to narrowing of blood vessels, we can see that mucosal damage can occur. In candidiasis, adherent gray-white pseudomembranes cover esophagus. Pseudomembranes are composed of fungal hyphae and inflammatory cells. In herpes virus infection, punched-out ulcers are seen. Biopsy findings are at margin of ulcer. Degenerating multinucleate epithelial cells are seen. Nuclei of these epithelial cells show viral inclusions. In cytomegalovirus infection, shallow ulcerations are visible, and characteristic nuclear and cytoplasm inclusions are seen in endothelial and stromal cells. Eosinophilic esophagitis. Eosinophilic esophagitis is a form of acute eosinophil-dominated esophageal inflammation associated with atopic disease. Morphology. On endoscopic examination, esophagus can take appearance of stacked rings called as feline esophagus or strictures or linear furrows. Microscopy shows large No. of intraepithelial eosinophils. These eosinophils can form clusters and sheets. Squamous cell carcinoma. Pathogenesis. Alcohol or tobacco use, nutritional deficiencies, mutagenic compounds, for example nitrosamine and polycyclic hydrocarbons, human papillomavirus. All these lead to number 1 amplification of transcription factors, for example SOX2, number 2 overexpression of cyclin D1, number 3 loss of function, mutation of tumor suppressor genes, for example TP53, CDH1 and Notch1. Morphology. Squamous cell carcinoma begins as squamous dysplasia. Early lesions appear as small gray-white plaque-like thickenings which over months to years grow into number 1 tumor masses that may be polypoid or exophytic and protrude into and obstruct the lumen. Number 2 tumor may be ulcerated or like infiltrative lesion that can further obstruct lumen. Most of tumors are well differentiated, which means they resemble cells of their origin. Less common histologic variants are number 1 verrucous squamous cell carcinoma, 2 spindle cell carcinoma, 3 basaloid squamous cell carcinoma.